Hi everyone, this is Tim, your Block 2 lecture instructor, and this PowerPoint is going to be, just like it's titled, just basic fluids. It is Chapter 13, and I know that Chapter 13 covers the basic fluids, but it also covers electrolyte balance and imbalances. I felt that the actual chapter was so large, and by having one PowerPoint for the entire chapter was going to take a really long time, and for me it was too long, and for you to listen was going to be even longer. So I divided it into two. This PowerPoint is actually going to cover page 165 to roughly, I think, 180. And then the next PowerPoint, which is labeled electrolytes, balance, and imbalances, is going to be another one. So I felt that this was going to be a little bit easier for you to understand, and then you're able to move on to the next PowerPoint. So here we go. So homeostasis, we've mentioned this in block 1, we've mentioned this several times, or you're going to hear it several times in block 2, but homeostasis is the balance of fluids and electrolytes. For me, I think that homeostasis is the balance of just everything in your body. Fluid overload, your body tries to correct it. You're dehydrated, your body tries to correct it. If you're constipated, it tries to correct it. Everything that goes wrong, your body is designed to try to correct it. It may or may not be able to correct it, but it tries its hardest to be able to do what it can. And that's where disease processes come in, and that's where we're here to fix. So homeostasis is the balance of fluids and electrolytes. This can be fluid outside of the cells, which is extracellular fluid. This could be fluid inside the cells, which is intracellular fluid, or this could be fluid between the cells, which is interstitial fluid. So with extracellular fluid, if there's too much, it's going to pull it into the intracellular fluid area. And again, if both of them are too much, it's going to pull into interstitial fluid, which is through spacing. So as we go on, you'll find that, again, just keep homeostasis in mind and just remember that your body is trying to balance. So for transcellular fluid, this is cerebrospinal fluid, this is synovial fluid, this is peritoneal fluid, and this is pleural fluid. With water, water is needed to deliver nutrients, electrolytes, and other substances to every part of your body. This could be organs, tissues, and cells. For the proper function, the volume of all bodily fluids and the types and the amount of dissolved substances must be carefully balanced. Again, homeostasis. So with diffusion, the free movement of particles across a permeable membrane from a higher concentration to an area of lower concentration. This is important for the transport of most electrolytes and other particles. So think of it as being, let's consider your vascular system, your circulatory system. If there is too much water in your circulatory system or your vascular system, it will push water and whatever follows it to other areas. So it can at least maintain some sort of balanced blood pressure, balanced pulse, because obviously it's going from a higher concentration. It can't take any more. That fluid and electrolytes have to go somewhere, so it's going to push it out. If you're third spacing, or if you're swollen, or you have fluid overload, it will actually pull it off the tissue and put it back into the vascular system. Again, it's trying to create homeostasis. So for osmosis, it's the movement of water only through a selected permeable or semi-permeable membrane. This could be isotonic, hypertonic, or hypotonic, and we'll cover those a little bit later. So bodily fluids. Bodily fluids are constantly filtered and replaced through intake and output. Intake is oral fluids, IV fluids, enemas, irrigation fluids, tube feedings. Output is urine, which is roughly 400 to 600 milliliters a day. Output could be emesis, feces, or drainage. Keep in mind both input and output, or intake and outtake. Anything that comes out of the body, out of any orifice, is considered output, and anything going into the body through any orifice is considered intake. And the reason why I say this is because what you cannot measure is solid food metabolism, perspiration, and vaporization through the lungs. So with solid foods, you can't measure that someone ate a hamburger. You can't measure that they ate French fries for lunch, or they ate ice cream for dinner. You can't measure something that's solid. You can document that they've had 50% of a meal, or 100% of a meal, or 25% of a meal, but that's not actually measurable. That's really a guesstimation of what they consumed. With metabolism, it's the same thing. You can't measure what your body burns off as things go on throughout the day. Perspiration is roughly 500 to 1,000 milliliters per day, but you can't measure someone's actual sweat. It's just physically impossible. With vaporization, this is you actually expiration of oxygen. You breathe in, and as you breathe out, it's not a matter of, well, as you breathe out, moisture actually is taken with it. So you do actually lose fluids as you exhale. But again, that's impossible to actually measure. So with hormonal regulation and fluid balances, there are three hormones. There's aldosterone, there's antidiuretic hormone, or ADH, there's natriuretic peptide, which is NP. So with aldosterone, when sodium levels are too low, aldosterone is secreted and tells the kidneys to reabsorb sodium and water from the urine and puts it back into the bloodstream. Aldosterone is also secreted when potassium levels are too high. So, as an example, let's say that you are running a marathon and you're sweating up a storm and you're losing tons of fluid and you're actually becoming dehydrated. Aldosterone is actually secreted and tells the kidneys, hey, instead of actually filtering all the fluid and sodium, potassium, and all your electrolytes out and whatever you don't need to excrete, it says, hey, you know what, we think we're getting dehydrated, so let's reabsorb some of this water and actually kind of put it back into our storage system so that when we do become dehydrated, that we at least have something to go on. I've always been taught that sodium follows water and water follows sodium. So kind of keep that in mind as we go through, and especially for the next PowerPoint, which is the electrolytes, their balances and imbalances. Keep that in mind. So as we go through, if you're going to, if aldosterone is going to be excreted and your body tells it to kind of reabsorb the fluid, it's going to pull the sodium with it. Aldosterone is also secreted when potassium levels are too high. So let's just say that you, ate a couple bananas and you took a couple of potassium pills, and all of a sudden you just have too much potassium. Your body says, hey, you know what? It's too much. We don't need it. Let's excrete it. With antidiuretic hormone, or ADH, this is also known as a vasopressin. So this hormone balances blood osmolality and tells the tubules and the collecting ducts in the kidneys to reabsorb more water if it's actually needed. So again, if you're starting to become dehydrated, or if there's if your body is kind of too much water, too much potassium, too much something, it's going to say, hey, you know what, let's actually start reabsorbing some of this stuff and actually kind of keep it in reserve. So it almost acts just as if the aldosterone does. With natriuretic peptide, which is NP, hormones are secreted by the cells lining the atria and ventricles of the heart. So this works the same way as aldosterone does, but opposite, and I'll explain why. So if you're having fluid overload and your body or your heart has to actually continuously pump out more volume, it's going to eventually get tired. Your atria and your ventricles are going to excrete a hormone, the natriuretic peptide, and say, hey, we can't keep this up. Let's start getting some of this fluid off. And it actually tells the kidneys to start pulling the fluid off and actually start urinating more. So it's almost as if your body's saying it's too much, let's get rid of it, and then let's excrete it out. So that's what NP does. In a nutshell, it decreases circulating blood volume and blood osmolality. So with renin-angiotensin II pathway, this is a little, I don't want to say it's too complicated, but once you get it, you're like, okay, this is very easy. It's on page 172 in about the bottom of the page, 13-6. And this is how I can explain it the easiest way. The kidneys are a major regulator of water. They balance sodium, they maintain blood pressure, and the perfusion to organs and the tissues. If you have low blood pressure, if you have low blood volume, or if you have low blood oxygen, renin is secreted and activate angiotensin I and bonds with angiotensin II. I don't want you to know anything other than that. You don't have to look into, chemical reactions or cellular levels or anything like that. All you need to know is that renin is secreted and it activates the angiotensin 1 and bonds with angiotensin 2. Angiotensin 2 is a vasoconstrictor, so it actually constricts your blood vessels. By doing that, that actually raises blood pressure. This will actually constrict atrials and cause adrenal glands to secrete aldosterone. And as we mentioned before, aldosterone is secreted and tells the kidneys to reabsorb sodium and water from the urine and put it back in the bloodstream, which makes sense because if you're having low blood pressure, low blood volume, or low oxygen, it one will constrict your veins and your blood vessels to concentrate the amount of fluid that you have, and then it tells your body that, hey, we need to start putting fluid back into the circulatory system, so let's stop excreting it. And salt follows water. So if that's the case, then you're going to start reabsorbing water, sodium, your blood pressure will go up, so will your blood volume and your oxygen level. I hope that makes sense, and if it doesn't, please bring this to class so I can explain it a little bit better, because I think once you do get it, it makes perfect sense. So FYI, ACE inhibitors, they lower blood pressure by blocking angiotensin 2. So if you have a patient who's on an ACE inhibitor, this actually does the opposite and actually blocks angiotensin 2 and causes a vasodilation, which actually lowers blood pressure. So patients who have high blood pressure, we give them ACE inhibitors so that way their blood pressure goes back down. So dehydration, fluid intake and fluid retention is less than what is needed to meet the body fluid needs. Makes sense, right? You run a marathon, you lose too much fluid, you're not drinking enough, you have dehydration. So mild dehydration can be corrected with matching intake with output. So if you, I think we had mentioned it before, if you perspire, and we know that it's about 500 to 1,000 milliliters per day, and you're running a marathon and you're not consuming that much fluid, then you're going to be mildly hydrated. Moderate to severe hydration occurs in those who cannot obtain fluids. This is older adults, adults with cognitive or motor problems. So with moderate to severe hydration, obviously it's worse than mild dehydration, but these are people who cannot physically obtain fluids to be able to correct the issue. So for your assessment, Gordon's functional health pattern. Daily fluid intake should be meals, snacks, and vitamins. Ask your patient, how is your appetite? Do you have difficulty swallowing? What is your daily fluid intake, weight gain, and weight loss? What's going to be different from block 1 to block 2 is now you're moving into the acute care setting. You're actually moving into the hospital. You're going to be taking care of people who, whether they live in a skilled nursing facility or at home, have some sort of somewhat independence. So you have to remember, if you don't ask the right question, you don't get the right answer. And I'll tell you why. So if I go to a patient who's 80 years old and I ask them if they're, how is their appetite? And they're like, well, it's okay. Well, define okay. Are you eating breakfast? Are you eating lunch? Are you eating dinner? Are you making these meals for one person or 5 people? Because you'll find that a single elderly person tends to skip meals because they don't feel like actually cooking because they're making too much food for just one person. So if they only eat cereal for breakfast and they eat a small snack in the afternoon and they may or may not eat dinner, to them over time that is a normal pattern. So if you say, how's your appetite? And they say, well, it's fairly good, but they don't really tell you exactly what they're eating, which we know after a while is not enough, then we're not getting anywhere. The reason why you have to ask them if they're having difficulty swallowing is because people who are elderly don't believe they actually have a problem. You'll learn through experience that you'll feed a patient, they'll take a couple bites, they'll swallow them, and eventually they start getting kind of that clearing of their throat. To them, that's not choking. To them, that's not a problem swallowing. All they're doing is just clearing their throat, and they just know that sometimes they eat a little too fast or they try to justify why they're doing it, and to them, that's not a difficult problem. But if they do, they're not able to consume enough food, which is not enough nutrients, so obviously they're not intaking enough. daily intake. I can tell you for a fact that people who live in Arizona already live on a daily basis dehydrated. It's 110 degrees outside. We don't drink enough fluids, and we are sweating off enough, but because the air is so dry, we're not actually seeing how much we're actually perspiring. So when you have somebody who's elderly or someone who is young that's running marathons, or you're having people who are just running around living busy lives who aren't drinking enough, they will tell you that their daily fluid intake is just not enough. So for weight gain and weight loss, again, you're actually trying to find out if they are eating enough to maintain their weight, and whether or not they're actually losing weight or gaining it. And weight gain and weight loss may be more of a vascular fluid problem as opposed to eating and gaining fat or muscle. So you're going to ask about bowel movements, how often, the character, the discomfort, and whether or not they actually use laxatives. And the reason why is you want to make sure that what goes in comes out. You want to make sure that what is coming out is normal. Laxatives could cause a lot of diarrhea, and with diarrhea comes a lot of sodium, potassium, and a lot of dehydration. With urination, it's the same thing. How often are you actually urinating? What is the color? What is the odor? And do you actually have control over your urination? Men tend to have prostate problems and will pee 5 million times a day, especially at night. They'll get up 5 or 6 times a night just to go because they can't continuously empty their bladder. With females, it's the same way. If you have a UTI, you'll find that you're going to urinate a lot, and the color is going to be dark, and the odor is going to be foul, and they may not actually have as much control. Older people lose, I don't say lose the ability to control their bladders, but they just don't have the muscle tone to be able to control it as much as they used to. Again, perspiration. Are you perspiring too much? Are you outside too much? Are you not being able to drink enough fluids to counterbalance the amount that you're actually perspiring? So for your physical assessment, you're going to check for cardiac changes. You're going to check for orthostatic hypotension. Blood pressure decreases with position changes. This could be a fall risk. One story came to mind. Most men who get up in the middle of the night to go to the bathroom, if they stand and to urinate, they will tend to lose blood pressure very quickly because of the fluid shift. That causes a fall risk. So if you have a patient who, comes in the hospital and he's on the cardiac unit and, he says, yeah, when I got in the middle of the night, go to the bathroom, next thing you know, I'm falling. It's because of the fact that he, got up from a lying position. He got up, he went to the bathroom, he's standing there, he's going to the bathroom, and his blood pressure actually decreased with the position change. For respiratory changes, increased due to reduction of perfusion and oxygenation. So if your patient is in either a fluid overload or there's some sort of pulmonary issue that does not allow them to actually perfuse and receive the oxygenation, they're going to breathe rather rapidly to be able to balance that out. So for skin and mucous membranes, you're going to assess for color, moisture, dry, and tuger. Patients who are very dehydrated are going to be more of a pale color. Skin is probably going to be very dry. They're not going to have the tuger. Or on the flip side, if people who actually have a fluid overload will cause their skin to be more pink and more of a moisture to it. Neurological changes, altered mental status that cause confusion. Low-grade fever causes more dehydration and causes causes them to be a fall risk. So for low-grade fever, this will tend to make your patients, when they finally break the fever, cause them to sweat more. Sweating, like I said, you can't really measure it, so it causes them to be more dehydrated, and that dehydration can cause them to be confused and make them a fall risk. So for kidney changes, you're going to monitor the urine output, you're going to monitor the daily weight, you're going to weigh them the same time every day with the same clothes. And the reason why is because if there is a weight change by a pound or two, that could be a fluid problem, whether or not they're actually having fluid overload or becoming dehydrated. But you want to weigh them at the same time because people who are weighed in the morning don't necessarily weigh the same as they do in the evening. And the clothes can kind of change that too. Urine may be dark and strong odor if they're too dehydrated. All right, so with labs, lab findings in your assessment, labs may change too. Your sodium, potassium, your H&H, and a couple of labs, tend to be off when you're dehydrated also. And let's see here, make sure I'm still on track. All right, so for interventions, patient safety is priority number one. Obviously, you're going to make sure that they're safe, that they're not going to fall, that they are reorientated. You just kind of do what you can do as far as making sure that they're safe. With fluid replacement, this could either be oral or IV fluids. You're going to make sure the patient can eat and swallow, because if they can't, then you have to do all other alternatives, whether it be tube feedings, whether it be TPN. You may need a swallow study to actually confirm that they can actually swallow well. You're going to measure their input and output. You're going to measure their vomiting, and you're also going to measure the diarrhea. The vomiting you can measure through graduated cylinder and emesis basins. The diarrhea you can actually measure through, we call it a hat, but it's a little bucket that sits in the toilet. Whatever you got to do, you got to kind of make sure that their input and output is being measured so you know whether or not they're actually becoming dehydrated. All right, so for fluid overload, it's not a disease but a symptom. It's excessive intake or inadequate excretion of fluid. I've mentioned this at least 10 or 15 times throughout this PowerPoint. It's the input or intake is going in, but it's not coming out. And this could be whether be third spacing, intracellular fluid, extracellular fluid. You're holding on to that fluid somehow. So for your assessment, for cardio, it's going to be increased pulse rate, increased blood pressure, distended hands and neck veins, and it's going to be weight gain. The fluid has nowhere to go but around your body system. So again, it's going to cause the fluid overload and the symptoms for the cardiac. For respiratory, it's an increased respiration rate and it's shallow respirations, and you're going to hear moist, crackled lung sounds because the fluid is actually building up in their lungs and they start to sound very wet. So for skin and mucous membranes, you're going to find pitting edema. At that point, the fluid has gone from your vascular system or into the intercellular or extracellular spacing, and it's now going into the third space, which is obviously edema. The skin is going to be pale and cool. For GI, you're going to see an increased motility, which is basically the stomach cramping. The book says you can actually see or assess an enlarged liver. They do show a diagram in there. I haven't in my career ever been able to really assess a good enlarged liver. So, but keep that in mind. So interventions, you're going to monitor their pulses, vein distension, lung sounds, peripheral edema, reduced urine, and you're also going to monitor skin for breakdown. You're going to turn your patient every 2 hours and get an air mattress if you actually need to. Patients that are having fluid overload and third spacing or swelling, that's when they're more prone to breakdown. And it's going to break down on their coccyx, their hips, their knees, their heels, their ankles, their elbows. Places that are very bony and promising is where the breakdown is going to happen because of that swelling. Other interventions are going to be drug therapy, which is going to be diuretics. One of them is going to be Lasix. And I put on here, watch your labs, because with Lasix, it's a diuretic that will pull fluid off of the body, and they'll actually excrete it. It'll cause them to urinate a lot. But with that urination with the urination will take with it sodium and potassium. You're also going to look at the nutrition. You want to look at a low sodium diet, which is going to be 2 to 4 grams per day, because again, water follows salt. So if you actually increase your salt intake, then you're going to keep holding on to that onto the water. So you're also going to monitor eyes and nose, making sure what goes in actually comes out, and checks our weights daily. Obviously, you're going to check it every day at the same time with the same amount of clothes. And 1 pound equals 500 milliliters of water. So if they gain 1 pound per day, that's 500 mLs per water that they've actually have saved and have not, gotten off or retained. And that seems to be it. So let's see, look at my notes real quick. There is one box that I wanted you to look at. And page 170, 13-1. So let's see here, 130, 13-1. This box is your major serum electrolyte lab. So your sodium, potassium, calcium, chloride, magnesium, phosphorus. I would, just as I suggested in your renal PowerPoint, memorize as many labs as you possibly can, because this whole block is going to be based on those, and eventually they're going to be needed. So I think that's pretty much about it. So I will continue on to the next PowerPoint, which is going to be electrolyte balance and imbalances. Talk to you soon.